Hello, this is Dr. Deborah Colony, Director of Emergency Medicine Ultrasound at the Arnott Ogden Hospital. Welcome to an echo-assisted evaluation of chest pain. In this video, you will learn how to use echo to supplement your evaluation of the patient with chest pain. On completion, you will have had instruction on performing the 4 basic echo views, plus a suprasternal view of the aortic arch. You will use a checklist plus clinical questions to help make a differential diagnosis of the patient with chest pain. With practice, you should be able to perform this exam in 10 to 15 minutes at the bedside. It's important to use a checklist and not leave anything out so that you get a clear picture of why this patient is having chest pain. You can use a list like I've given you, or you can use a mnemonic device: A, B, C, D, E, F, aorta, both ventricles, C for contractility, D for dimension, E for effusion, and F for further abnormalities. If you're not familiar with doing echo, it's really just like any other type of ultrasound. You have to remember that the two-dimensional beam is just a little wafer-thin sliver, and unless you pass it through the object and point at the object, you won't see the object. You can be right next to it. If you don't have the beam across it, you will not see it. Your basic movement with the beam is fanning. You can also rock heel to toe, but fanning is your friend. You will not see the object unless you get the beam across the object, and when you do see the object, you only see a slice of it. The beam is not a camera. It does not show you the whole object. It shows you a slice. An echo machine is just a box with buttons on it. M mode is motion mode. I'm going to show you how to use that. Color just puts color across a valve or any other structure where there's flow. Blue away, red towards. B is for brightness mode. Makes a picture like a photograph of the slice that you're looking at. Freeze freezes the image so you can save it. Save saves an image or a video. And on any machine you will find gain buttons that allow you to adjust the near and far gain of your picture to make it brighter or darker as you need. Push M mode twice, once to get the cursor and again to get to the M mode picture. Push update to see where your cursor is. If lost, push B mode to get back to a picture. The depth key allows you to get closer or farther from a desired object. You'll want to get a parasternal long axis view between the 3rd and 4th intercostal space parallel to the sternum at 11 o'clock. Parasternal short axis, rotate your transducer to 1 o'clock. Apical forechamber, go to the apex of the heart, point your marker towards the left axilla. You can also get an aorta suprasternal view, and I'm going to show you how to do that later. The most important thing is, once you get your patient positioned on his left side and you take a view, you'll probably get that view. Don't slide down the chest wall. If you hold the transducer like a pencil and put your pinky finger out on the patient, then your hand won't slide off the patient. At first you might not be able to see the heart, but if you make a rotary motion, the heart will come into view. Mike is making a perfect round circle, and you can see the heart coming in and out. This is called window shopping. This patient is positioned very nicely for a parasternal long axis view. That beam is slicing right across the long axis of the heart. The marker is oriented toward the patient's head.
First thing we want to do is get a good window, and we'll circle around and stumble into our window. And then it's very easy. In this case, look at the apex. I'm cutting it off. And I'm also cutting off the aorta a little bit. This, and many times, is a simple twisting of the transducer. You can see now I'm just twisting the probe, and that is what's causing that view. Oh, let me go my circle and find my view again. That's what's causing the collapse of the left ventricle and the aortic root is just a twist. So make sure in that particular case when you're cutting off the aorta and the ventricle that a twist can really help you find the best window or improve your window that you've already found. Now in this particular case, I've got a very nice parasternal long axis view, but it is indeed very low. I wouldn't want to do my M-mode measurements from here. So usually the fix for this low window is to move closer to the sternum. See how the ventricle is getting flatter now and flatter still. And now I can do my circle where I'm at, where I have a nice flat ventricle, and fine tune that image. And now I've got a good parasternal long axis view. Now it might not be as pretty as the lower view was. It might not be have the aesthetics that we'd like to see. So in that case, you want to go ahead and do your M mode from this flat window. So you're sure you've got a nice perpendicular M mode. And you can see the aorta is kind of drifting away there. A little adjustment. Now I can open up the aorta again. But now when we want to get our 2D view, we want to surely see the aorta and the aortic valve. This is a nice flat view for good M mode, but now it may be time to go ahead and slide to that little bit lower window so we can have a nicer 2D view. Go ahead and use this view for your 2D and then use the flatter view for your M mode. So you're most accurate in both cases. We want to make sure we're perfectly round. You don't want to have a off-axis, short axis view because you won't be seeing the chambers that you expect you should be seeing. So in this case, here we have a perfect mitral valve. The best place to check for how round you are is with the mitral leaflets. So we can see both leaflets across. They're horizontal across the screen more or less, and they're completely parallel to one another. Now if I'm not perfectly twisted, you can see that we're kind of coming to a point on this side and we're open on this side. That means I need to twist the transducer. If it's open on this side, I'm going to twist the transducer in that same direction to the right. It's open on the right, I'm going to twist the transducer to the right. If I'm over twisted to the right, then the bottom of the triangle is on the left. So I need to twist the transducer in the direction of the open side, and now by twisting the triangle goes away. Let me get that back for you again. So you can see the point is over on this side, the open end is on this side. So I'm going to twist it in that direction to the left and flatten out my mitral again. So now I do have a good cross-sectional view. And you can use that to make sure you have a good cross-sectional view when you're looking at the LV as well as looking at the aortic valve. The best landmark to choose from is make sure your mitral is squared up or truly perpendicular to the long axis view, and then you'll have the best aortic valve and left ventricle views.
This way you will be able to obtain a good parasternal long axis view of the heart. Remember, the ultrasound beam is a thin slice, and you're only looking at a slice of the heart in 2 dimensions. Is M mode scary? No. Can you do it? Yes. Just push the button marked M. To obtain some of the data that you need, you will have to go to M mode. And this is not complicated, it is just motion mode. The machine makes a linear picture of the moving objects in front of it, and therefore it doesn't need to record as much data, and you can get a really simple picture and some measurements quickly. Your machine has an M mode button, and we're just going to press that. The first thing you'll see is a cursor, and you can move that cursor back and forth across the moving picture. And right now, first thing, we're going to put it across the aortic valve area. And you're going to see a sine wave pattern and a pattern like a box just below it. Remember, you usually have to press the M mode button twice, once just to see the cursor, and then again to see it go into M mode. And you can move the cursor back and forth to position it where you want. Here's a labeled schematic. The open box is the open aortic valve. The closed lines in the middle are the closed valve leaflets. Black space at the top is the RVOT. Black echo-free area at the bottom is the left atrium. Why do I care about this? Because the aorta, when it moves, it swings and makes a nice sine wave curve up and down. Now, when you see that sine wave start to flatten out and lose its nice arcing curve, that's your first clue that you have left ventricular systolic weakness. Freeze that picture, save it. Again, here's an M-mode depiction of the aortic valve with good excursion. It's moving very well because it has a strong ventricle pushing it. Here there's almost no sine wave. The excursion is very flat, and you know you have a weak left ventricle. Once you've got that picture, then you're going to swing your cursor to about 6:30, and you're going to be right over the mitral valve leaflet tips. And you can look at that, you can see the mitral valve moving, and position your cursor correctly. Now you haven't changed your view at all, you just moved your cursor, and now you put it over the mitral valve leaflet tips. Push the M or M mode button. Push the freeze button. You'll get a picture that looks like this. And then you'll see two peaks, E and A. E means the wide excursion of the anterior mitral valve leaflet in early diastole, which is a passive filling of the ventricle. And you'll see that that leaflet tip approached the septum. And you can use that number, the EPSS, the endpoint septal separation, to judge a ventricular function. The wider that septal separation gets, the poorer LV function you have in general. In fact, you can use an empiric formula, which is 75.7 minus 2.5 times the EPSS in millimeters, and you can use that number as the ejection fraction, and most of the time you will be very accurate to the true ejection fraction. It's only not accurate if the mitral valve leaflet is tethered somehow and can't approach a septum because it is fibrotic and scarred down. But most of the time, this works very well. So after you save your E to A picture, then you're going to swing your cursor to about 7 o'clock. You haven't changed your window, and now you're seeing right across the left ventricle. So why do I care about that? Because now you can measure the width of the ventricle in systole and the width in diastole. Just like a computer, you have to freeze the image before you can operate on it. Then get a caliper and measure those distances. The widest is in diastole and the narrowest is in systole. Now the operator rotated the transducer to the 1 o'clock position without moving anything else, just rotated. Now you see the tricuspid valve to the left of the screen and the aortic valve in the middle of the screen. Aortic valve looks like a Mercedes-Benz sign. It should have 3 cusps. The tricuspid valve is thin and it divides the RA from the RV. You can see it there. Just using the depth key to come up a little closer on that, we can see that our cursor is right across the tricuspid valve. Once we looked at the aortic valve level, we're going to pan down to see the mitral valve level and eventually down to the papillary muscles. The most superior valve is the aortic, then the mitral, then the papillary muscle. Now you see septal, anterior, lateral, inferior walls of the heart. Look for wall motion abnormality. You can look at these letters, septal, anterior, lateral, and inferior, and those represent the walls of the left ventricle. And you look at those to see if they have an equal contraction. Look for a wall motion abnormality. Look for a segment that's being dragged instead of contracting. This septal portion is not contracting, and it creates a hinge effect. You can see part of it's being dragged. It can be old or new, but if it is new, and you see it acutely in the presence of chest pain, it is probably due to ischemia. In this clip, taken from an apical 4-chamber view, the apical portion of the septum is very thin and is not contracting. This is a wall motion abnormality. They can be subtle and hard to see.
So what if we could include as part of our assessment an actual functional picture of that ischemic myocardium? Echocardiography allows us to assess myocardial dysfunction in real time. This can be helpful and has been proved to enhance identification of acute ischemic events used as an adjunct to EKG. Previous studies have shown that regional wall motion abnormalities, that is, the dysfunction of one specific region or segment of the ventricle due to an ischemic insult, to be the first sign of acute cardiac ischemia.
Here, one more time, the same clip with coloring to help us memorize the anatomy and the regionalization for the assessment of wall motion abnormalities. Now this EKG highlights exactly which leads correspond to which regions of the heart. Thinking back to your board exams, you will remember that the three primary arteries of importance feeding the different regions of the heart are the right coronary artery, or RCA, which generally feeds the inferior heart, the left anterior descending artery, or LAD, which generally feeds the anterior heart and the septum, and the left circumflex artery, which generally feeds the lateral heart. We can therefore think of the EKG leads in terms of coronary distribution as well, following this anatomical simplification. Now let's take a look at some pathologic EKGs and see if we can identify which region of the heart and corresponding coronaries are likely to be involved. Do we see signs of infarction here? Certainly. We see ST elevation in leads 2, 3, and AVF. This corresponds to the inferior wall, which is generally supplied by the RCA. Where do we see contiguous ST elevations in this EKG? In the precordial leads, V1, V2, V3, V4, which correspond to the anterior and anteroseptal walls. Here we see this highlighted in red. Where do we see ST elevations on this EKG? In 1, AVL, V5, and V6, which correlate to the lateral wall. Here we see that the lateral wall is likely to be involved, which is generally supplied by the left circumflex artery.
Think for a moment, where would you look for regional abnormality in the echocardiogram of this patient? Here it is on a parasternal long view. Pay attention to the same clip now by looking carefully to the inferior wall. You can see how the part of the ventricle is not participating as well as the other segments. What about our parasternal short axis? Where do we expect to see a regional wall motion abnormality here? Look to the inferior portion of the heart and slightly to the left, where the right side of the heart falls and where the RCA would feed to. Finally, where do we expect to see an inferior wall MI on the apical forechamber? Exactly. The RCA feeds part of the intraventricular septum along with most of the inferior wall, as shown in the clip on the right. Look carefully and see how the image on the left, the inferior septal region is not contracting as well as the rest of the left ventricle. This is consistent with the changes we saw in the EKG.
Now let's look at this one. We have a patient with active chest pain. Where do we see ST elevations in this EKG? It seems to be the anterior leads, mainly correlating with an LAD lesion. In fact, we already saw this EKG, but let's see now where the anterior wall is visualized on echo. This is a slightly rotated parasternal long view. You can see how the anteroseptal region here is contracting abnormally. If you're having trouble identifying this, put your hand and cover the rest of the walls and focus on one segment or region at a time. By doing that, the abnormality becomes much more clear. Just like EKGs, there's a learning curve for this skill. The more you see, the better you will get. Of course, you have to know what you're looking for. Here is a parasternal short view of the same patient. Look at the anterior wall on top of the image. Clear, right? Sometimes the abnormalities will not be completely evident in one view, but integrating the information and looking directly at the same regions in each of the three views, parasternal long, short, and apical forechamber, will allow you to pick them up. Here it is side to side with our colored image.
And in case you're still not convinced, here it is the same patient, now on the apical forechamber view. And here next to the normal colored image, look at the region corresponding to the anterior and septal walls irrigated by the LAD, On our clip on the left of the screen, this wall is barely contracting. Finally, where do we see the MI here? It is along the lateral wall, fed by the left circumflex. Ready to see the echo? Pay attention to the lateral left ventricle wall on the left of the image. Remember the colored region that corresponds to the lateral wall? We made it blue for the purposes of this module. Here it is. See how there's no great contraction on this region compared to the rest of the segments? Alright, let's wrap it up. In order to assess regional wall motion abnormalities, you need to remember 3, 3, 3. 3 echographic views, 3 left ventricular regions, and 3 coronaries irrigating most of these regions. The 3 views are the parasternal long axis, the parasternal short axis, and the apical four-chamber view. The 3 regions are the anterior wall corresponding to the left anterior descending artery, the lateral wall corresponding to the left circumflex, and the inferior wall corresponding to the RCA. Here we see all 3 views with all 3 walls highlighted and correlated to an EKG. Hopefully, by the end of this workshop, we will be able to identify regional wall motion abnormalities and relate them back to an EKG.
If the right ventricle is bloated and squashing the left into a D shape and diastole, this is volume overload of the right ventricle. If that RV stays bloated and the LV retains a D shape in systole, that's pressure overload. Acute pulmonary embolus may cause these volume and pressure overload changes. Here is a video in which the operator went from long axis to short axis, and you see a pretty hefty pericardial effusion in this patient. You know it's pericardial because it's above the aorta, and now he went short axis, you can see that. Now he went to apical four-chamber, and you can see the wall of the right atrium collapsing during systole. This is the first sign of tamponade. Let's look at that again. That fuzzy, hairy, round thing just below the effusion is the descending aorta cut transversely. If the effusion is above that, it's pericardial. If it's below that, it's pleural. So get a good look at this pericardial effusion with tamponade. As we go through the 4 views of the heart, we're going to do an apical four-chamber, and that's just shot from the apex with the marker pointing towards the patient's axilla. Make sure you're really on axis to get this view, and look for a wall motion abnormality. You can also put color over any of the valves to see if there's regurgitation or stenosis. Here's some tricuspid regurgitation in systole. Blue away, red toward. Get your transducer parallel to the blood flow. You'll see a good flow away from the transducer. The diameter of the right ventricle and left ventricle should be noticed. That ratio should be 0.6 to 1. Now let's go to a very different looking heart. This heart is hyperdynamic. The apex of it is contracting, but it's just dragging the right ventricular wall along with it. And you can also see the diameter between the right ventricle and the left ventricle is almost equal. In fact, the RV looks bigger. So what happened to this patient? It looks like something plugged up his right ventricular outflow tract, and that is usually a pulmonary embolus. This sign, the moving apex dragging the RV, is called McConnell's sign. It is not specific to pulmonary embolus. It can also occur in right ventricular infarction. However, it is a red flag that something is really wrong. In our comprehensive exam of the chest, we're also going to look at the lungs. This is a normal lung. It shows in repeated reflections of the pleura caused by reverberation artifact, which is common to ultrasound. If you see a series of curved white horizontal lines, then that is a normal lung. Here is a not so happy lung with a large pleural effusion and a fragment of lung that's collapsed, sort of floating in the breeze. So that's what pleural fluid looks like, a big black sea. You will see this frequently. It's easy to detect and very much worth doing. We looked at lung with A-line artifact, which is normal lung, but what is this? This is highly akin to shining a flashlight into a foggy sky. You see a whole lot of lung comets. They must extend the length of the sector and they should be 3 to 7 millimeters apart. And if you see these, they indicate pulmonary edema. Remember M mode? Well, push that button. These are waves at the beach, normal lung in M mode. Now this patient has a pneumothorax, and the waves have disappeared, and all you see is a barcode sign. So M mode, lung, barcode, bad. Now we're going to go back to the parasternal long axis and the aorta. Parasternal long axis is between the third and fourth rib spaces. Transducer close to the patient's sternum at 11 o'clock. However, as patients get older, their hearts drop down and become more horizontal. Just make sure you're on the long axis of the heart. And if you're looking for the aortic root, you may want to go one interspace higher. The relative diameters of the right ventricle, aortic root, and left atrium should be the same. If you see one chamber is much larger than the other, then you realize you have a problem. Here that is in M mode, and you can see that the diameter of these chambers is approximately equal, 1 to 1 to 1. Right ventricle on the top, aortic outflow tract on the middle, and the left atrium on the bottom. And it's all parasternal long axis view. It's easy to freeze your image at any time just to look at those parameters of measurement. If you see an aortic root which is 4 centimeters or greater, then you really seriously need to look for a dissection. Here is a dilated aortic root, and you can see that it has a much greater diameter than the RV, which is above it, and the left atrium, which is below it on a parasternal long axis view. So you want to look at that ascending aorta, and in the next picture you will see a dissection flap. There's a very easy view of the ascending aorta and aortic arch that you can get by placing the transducer in the suprasternal notch and angling the transducer at 1 o'clock and fan up and down until you see the aortic arch. You should be able to see the left subclavian artery, the left common carotid, and the innominate or brachiocephalic. And the small round area, clear area in the center, is the right pulmonary artery. Here's a dynamic view of the aortic arch, and I put some color across it. You can do this too. Just push the color flow button or CFM button. And the mnemonic for this is BART, blue away, red towards. Red indicates flow towards your transducer. Here are some pictures of the aortic arch with dissection as seen on transthoracic echo. It is important to realize that transthoracic echo is not the gold standard for detection of aortic dissection. CT angiogram, TEE are much superior, but not always available methods of imaging. The esophagus is a hollow, air-filled, or sometimes fluid-filled organ that is very hard to visualize with ultrasound, and you won't be able to see it. So this part of the exam is clinical question about GI symptoms. Be sure you ask them. And be sure you ask about chest wall symptoms and simply observe if the patient has pain when he moves his thorax or pain when you press on the thorax. Don't forget to ask about personal stress when you are examining the patient with chest pain, anxiety, hyperventilation, lack of sleep. All of these things can cause chest pain. People who are trying to quit smoking get chest pain. People who smoke marijuana get chest pain. Some people in our society are working 2 jobs. They may be going through a divorce or have problems with their children. So ask about stress, and you may well uncover the cause of chest pain if you have not found another cause. Hopefully, if you've been methodical with this exam, you should now know if the patient has a pericardial effusion or pleural effusion, if he has chest wall tenderness, esophageal symptoms, reduced LV function, reduced ejection fraction, an aortic dissection flap in the ascending aorta or aortic arch, or if they have McConnell's sign, a dilated right ventricle, plethoric vena cava, or other sign of acute pulmonary embolus. You should also be able to determine if pneumothorax is present. It's important to practice if you want to have this exam. Use good echo windows, use B mode, use M mode, follow a checklist, and use the correct probe to examine the patient. I hope you have enjoyed this presentation and that it will enhance your examination of patients with chest pain in the emergency department.